We have a wonderful speaker today, Dr. Bob Roshanravan. How'd I do?
Good. Excellent, yeah.
All right, Friday's going well. Ready for the holidays. He is an expert in chronic kidney disease. He's a nephrologist, and his area of study really focuses in on how chronic kidney disease affects functional status. So this is his work is very closely related to a lot of what we talk about in geriatrics, with changes of function and really focusing on optimizing function. So I will turn it.
Great. Thanks so much, Kate. Thanks for the invitation. In a 15-minute allotment, I'm presenting a lot of data in 15 minutes, but the slide set, which I believe will be handed out to everybody, has much more data, so you can, and my email is also on there, so if you have any questions. So the topic today is really talking about kidney disease and its management in older adults, as well as the association of kidney function with functional decline in the older adult patients. So the outline in this short time period, I'm going to just briefly touch on how we measure kidney function and some of the management issues in the older adult population with chronic kidney disease, comparing adult and older adults, and talk about how kidney disease leads to sarcopenia or impaired muscle function, and that begins the process of functional decline in these adults before the onset of dialysis. And then we'll talk about whether dialysis is the appropriate option for older adults, and what are some of the major studies that look at the differences between initiation of dialysis versus conservative management. And then I'll wrap up. So when we estimate GFR, glomerular filtration, as a marker of kidney function, we're only looking at a snapshot. And creatinine is a very imperfect assessment. Serum creatinine is an imperfect assessment of kidney function. And that it's important to recognize that the kidneys do more than just filter. They also secrete. And a lot of the drugs that are excreted by the kidney go through the secretion pathway, not the filtration pathway. So you're only getting a glimpse into the actual kidney function. And creatinine is not a great marker for kidney function because it's confounded by multiple issues, particularly muscle mass differences, whether there's a component of malnutrition, if their patient has decreased muscle mass because of amputation, or liver disease, which is also related to malnutrition. Then there's also the impact of medications on the actual secretion of creatinine, which can falsely decrease glomerular filtration rate, masking or actually artificially showing reduced kidney function. It's important to understand in this graph here, do I have a mouse? Oh, here we go, yeah. That when you get to lower kidney functions, larger differences, lower glomerular filtration rate, the larger differences in creatinine mean less at that stage. However, when you're at the higher end, smaller differences in creatinine make a big difference in terms of glomerular filtration rate. Keeping that in mind, the association is not linear by any means. Also taking into consideration the medications that patients are on, trimethoprim, for instance, cimetidine, if not used much anymore these days, but Bactrim is used. That can artificially decrease the glomerular filtration rate by decreasing creatinine secretion. And when it comes to prognosis, the Kidney Disease Quality Improvement Expert Panel, the KDIGO, released a graph to sort of identify prognosis in kidney disease, whereby they categorized individuals in terms of persistent albuminuria categories and glomerular filtration rate. And the red bars signify the almost synergistic effect of the both having significant proteinuria and declines in GFR on cardiovascular and all-cause mortality outcomes. So you can see the GFR 60 to 89 with mild proteinuria is green, whereas if you have significant kidney function decline with significant proteinuria, it forebodes a very poor prognosis. This has implications for also evaluation and planning. So on this chart, you'll see that at stage 3B, which is GFR less than 45, this is where you start to think about bone and mineral metabolism disorders, elevated PTH and phosphorus, and what to do with vitamin D. So that's important. So the management issues in chronic kidney disease center around glycemic control, blood pressure targets, and how to prevent progression to dialysis. And we'll start with the first one, which is glycemic control. It's of paramount importance in reducing cardiovascular disease risk in patients who have who have relatively preserved kidney function, preventing kidney function decline, and also among those that have combined diabetic kidney disease. In the UK prospective diabetes study of type 2 diabetics, a 1% reduction in hemoglobin A1C was associated with a 35% reduction in both microvascular endpoints and 18% in MI, with a significant impact on reducing all-cause mortality. But there's a challenge, in particularly in older adults, that we have to keep in mind, and that's the risk of hypoglycemia. When it comes to treating diabetes, it's important to identify whether or not you have incident diabetes or recent onset diabetes, or if you have prevalent diabetes. And unfortunately, many of the older adult patients who are diabetic may have a long-standing history of diabetes and microvascular complications, such that if you look at the ACCORD trial, which looked at tight glycemic control among those who are at higher cardiovascular risk, they found really no difference between standard and intensive control of glycemia in these diabetics. Whereas if you catch them early on in life, such as in the DCCT edict trial, you can see that more intensive diabetic control has a significant effect in reducing the onset of impaired kidney function. So keep that in mind. Given this data, the expert guidelines recommend that you target hemoglobin A1C of approximately 7 in these patients with CKD. And there's a biologic basis for that, and that is that in advanced CKD, there's not a good correlation between the mean glucose and the hemoglobin A1C. As you can see here, it apparently didn't come out, but this is in normal patients. But if you look at the regression coefficient of patients with CKD, it's almost half the strength of the association between mean hemoglobin concentration and hemoglobin A1C. Plus, if these individuals are on EPO or they're getting supplemental iron, it reduces the correlation even further. So keep that in mind. Maybe there should also be there's a recent push to consider continuous glucose monitoring in these patients who are rather complicated and prone to hypoglycemia. So have a low threshold to potentially refer these patients to endocrinology clinic if you're worried about frequent hypoglycemic events. In this large retrospective study, they also looked at, in older adults, what was the incidence of hypoglycemic events with reductions in GFR. And you can see that with reductions in GFR, there's a substantial increased incidence of admission with hypoglycemic events. And if you look at the KDIGO categories that I told you, the high-risk category, which was in the red, was substantially associated with increased risk of hypoglycemic events over 3 years, so among diabetics. So keep that in mind. So what are the reasons for this challenge with treating glycemic control? Well, the anti-glycemic meds are metabolized by the kidney and can accumulate. Insulin in particular is cleared by the kidney, so it can last around longer. You also have the fact that in kidney disease, the kidney is a substantial organ of gluconeogenesis, so it's a counter-regulatory organ to prevent hypoglycemia, and that is impaired. So that's another situation. Then you also have the fact that older adults have lower glycogen stores. They're more malnourished, for instance, in these individuals. So they have a decreased counter-regulatory response. And many of the older adults are also on beta blockers, which can mask hypoglycemic symptoms. As well as polypharmacy is a major contributor because of potential for cognitive dysfunction when they're on, for instance, antihistamines. Or keep those in mind. But what about treatment of hypertension? Well, it's important to understand what's going on in kidney disease and chronic hypertension and diabetes separately when you're trying to figure out how to treat these patients. In the normal kidney, you can see this is the glomerulus with a bundle of capillaries. You have your afferent and your efferent arteriole here. When you get diabetes, you have a dilation of the afferent arteriole and a constriction of the efferent arteriole via angiotensin II. And that has an impact of facilitating hyperfiltration, whereby the filtration pressure builds up in the glomerulus and you get spilling of protein and albumin in particular. When the spilling of the protein and albumin exceeds the reabsorptive capacity of the proximal tubule for those proteins, you get early onset microalbuminuria, which is important to keep in mind. What is the main treatment for this? Well, it's an ACE inhibitor if a patient can tolerate it. And the ACE inhibitor works by reducing glomerular pressure by dilating the efferent arteriole. And once there is already chronic kidney disease, it's important to understand the expected change in kidney function with the initiation of antihypertensive therapy. On this chart, you have your glomerular pressure, which is, and in addition, on the x-axis, you have your mean arterial pressure. The normal curve for a patient allows for autoregulation over a broad range, whereby over a mean arterial pressure that's quite long, you have a ability to regulate the amount of pressure that the glomerulus sees and mitigate the pressure damage that can occur to the kidney. But if you have chronic hypertension, you have a rightward shift whereby you're relying on higher blood pressures to maintain perfusion of that kidney. And if you have already chronic kidney disease, then you have a decrease in that autoregulatory environment. And this is why you can see substantial increases in creatinine with the initiation of an ACE inhibitor, for instance. You can have them fall off the equivalent of the Starling curve for the kidney, basically. So what is the best target for blood pressure control? The most comprehensive study to date, and controversial at that, for determining what is good blood pressure control among older adults has been the SPRINT trial. Now, keeping in mind that these individuals, although they were at high risk of cardiovascular disease, none of them had diabetes. And they excluded pretty severe kidney dysfunction with a GFR less than 20 or proteinuria greater than 1 gram. They tried to assess in a randomized control trial setting that was trying to really assess the efficacy of blood pressure control. What was the effect of reducing blood pressure to less than 120 and compared to usual care, which was deemed less than 140 systolic. And it's important to understand after year one, they achieved almost like 124 millimeters of mercury versus 136 millimeters of mercury. So that was what was achieved in year one. And if you look at the results, there was a substantial reduction in the risk of cardiovascular events and all-cause mortality with the intensive treatment group. But it's important to keep in mind the fact that and this has been brought up by many editorials, that what we see in a clinical trial is really an assessment of efficacy and not necessarily effectiveness. What is the difference? Well, efficacy is really testing a drug's effect in the ideal setting, not the real world setting. The real world setting is an assessment of effectiveness. And if you look at what happens in a randomized controlled trial setting and how they measure their blood pressures, it's quite different from the office setting, such that they used a standard protocol where the patient immediately came into a quiet room and had rest for about 5 minutes before they got 3 automated blood pressure measurements. Whereas if you think about what's going on in a regular practice, you get the patient to sit down, they don't really relax, and they immediately get a blood pressure, and you rely on that one blood pressure for everything. They also, at every visit in the randomized trial, routinely assessed orthostatic blood pressure. And in the clinic, you ask about it, but don't actually evaluate it. So there's quite a bit of a difference between what is in the real world and what is in the clinical trial setting that we have to keep in mind. Now, granted, if you are able to do a treatment protocol in the ideal settings, they noted that irrespective of the underlying frailty status of these patients, aggressive blood pressure control had a significant effect in lowering cardiovascular events and mortality. So, so if you can do it, great, but do it cautiously and do it in a use measurement of blood pressures that's more precise than in the office setting. And now there's a push toward using home blood pressure measurements or automated blood pressure readings, 24-hour ambulatory blood pressure monitors. But still, after the publication of this trial, there's still been some controversy about what is the best blood pressure to treat. And the American Diabetes Association recommends a blood pressure of less than 140/80, particularly in diabetics. Whereas if you have chronic kidney disease with albuminuria, because these patients are at risk of significant progression, they recommend a blood pressure of less than 130/80 if possible without causing harm. Keep that in mind. The new American College of Cardiology and American Heart Association guidelines released a pretty blanket recommendation where they recommend treating patients to a blood pressure goal of less than 130/80, which is quite aggressive. And the evidence for this is rather lacking at this point for a blanket statement. It's based on pretty much the SPRINT trial, but they do recommend that more reliance be placed on home blood pressures measurements and consideration of ambulatory blood pressure monitoring, so in patients who are at high risk for complications in particular. What else can you do to prevent progression? Well, there's been studies that have shown that you can recommend correct for metabolic acidosis, and metabolic acidosis has a significant impact on progression of kidney disease because it's thought to actually activate the inflammation that occurs in the tubules of the kidney. This study looked at bicarb supplementation in more advanced kidney disease, and they noticed that giving bicarb to patients who had metabolic acidosis with a bicarb of 16 to 20 actually reduced the risk of progression to dialysis and improved some nutritional parameters. Now, this is a rather small study, and a larger randomized controlled trial is taking place in the United Kingdom. But what about in the older patients? What is the risk of really progressing to dialysis? Dialysis is not a very common event, and even in randomized controlled trials, the progression to dialysis is rather limited in number in terms of outcomes. When you look at the age of the patient, that can determine where they're more likely to die of cardiovascular disease than they are to progress toward dialysis, such that at about the age of 65 and 65 to 74, you see that the risk of progression of actually progressing to dialysis is actually less than the risk of progressing to having death. So it's important to keep that in mind. The age, there's quite a bit of heterogeneity between age, but this suggests that on average, dialysis may not be the right decision for everybody, and that the risk is greater for patients who are above 65 for cardiovascular death than going to a dialysis. But what can we do to potentially prevent the functional decline and the symptoms of dialysis? Well, it's first important to understand how kidney disease, even before the initiation of dialysis, can lead to functional decline. And many of you know about the Nagy model of the disablement process, and chronic kidney disease fits into this model quite well, whereby chronic kidney disease is traditionally associated with inflammation and oxidative stress, and we've shown that it's been associated with the onset of sarcopenia, and that is the final common pathway for all the processes that lead to functional decline and mobility disability. And when the patient the demands of the environment exceed their capacity to actually interact with their environment, they compensate by reducing their physical activity in that environment. Ultimately, different aspects of this disablement process, such as muscle impairment, functional limitation, and disabilities, can actually progress to the phenotype of frailty. And that phenotype of frailty we've shown is associated with the onset of early dialysis or death. So, what evidence do we have? Well, in the older adult population, we did a study where we looked at the association of kidney function with ambulatory muscle quality. This is the muscle density of the calf, which is equivalent, an imaging equivalent to the quality of the muscle. And we saw that per 10 cc reduction in creatinine clearance, there was equivalent to 1 year of advancing age in terms of the reduction in the quality of the muscle, and that was after a complete adjustment, including physical activity. And that has significant consequences. As you can see here, this is the knee extension strength of the quadriceps muscle, and this is the exam age in years. You can see that those people who had the lowest kidney function had the most rapid decline in their knee extension strength compared to those that were that had normal kidney function. So it's important to assess frailty and disability in this population. And what other evidence do we have that there's a significant risk of frailty? Well, this study by Bellew and colleagues published in the American Journal of Kidney Disease showed that there's a significant increase in the risk of frailty based on your albuminuria and your GFR. So in line with what we discussed earlier. And what about the dialysis initiation? What can we expect to happen when we do start dialysis on patients? Well, dialysis can be a poor choice for some people. And if you look at this National Registry of Nursing Home Residents who started dialysis, they conducted and published in the New England Journal of Medicine by Corella Tamura. They looked at functional status changes after the initiation of dialysis. And this is their results. So you can see here that before the initiation of dialysis, there is some decline in functional status from baseline in these nursing home residents, but you do not see any increase in functional status after the initiation of dialysis. Now, this is obviously in a nursing home residents, but you can also see that the cumulative mortality rises. So I would not say that dialysis will improve quality of life for individuals. And if you look here from the time at which they start dialysis, the majority of individuals in this nursing home population either died or they had a functional status decrease Only about 30 to 40%, less than 40%, had any functional status being maintained. And that proportion of death and functional status decline goes up quite substantially. So dialysis is no panacea. What about dialysis versus conservative management? Well, there was a study in the Netherlands that looked to answer this question about whether or not conservative management has a role in patients with advanced kidney disease. It was a retrospective study. They looked at those individuals that chose renal replacement therapy and those that went on to conservative management. And the point of this study was that among those that were 80 years and older, there was no survival benefit between those that chose conservative management versus just initiation of dialysis. There may have been some improved survival in those who were younger. And in terms of quality of life, there was another study borne out in Australia where they looked at renal supportive care compared to usual care in the pre-dialysis clinic. And this renal supportive care was staffed by a palliative care specialist, a senior renal and palliative care nurse, and a dietitian. And obviously, the decision to go on to dialysis or not dialysis was left up to the patient. So this was not a trial, but it was an observational study. And you can see that probably the most important thing that you saw here is that although those people that chose dialysis lived longer, there wasn't an actual difference in the quality of life between those that chose dialysis and those that chose renal supportive care. So quality of life can be maintained, though survival may decrease. And obviously this is a biased sample because those who chose dialysis may have been fundamentally different than those that did not. So the impact, in summary, the impact of survival of dialysis can improve survival among some individuals, but among those that are 80 years and older with multimorbidity, it's quite questionable at this stage. But ultimately, it's important to have shared decision making with the healthcare team when initiating dialysis. Why is dialysis potentially harmful and reduce quality of life? This will give you a brief animation about what harm we do to patients when we do dialysis. So you see, this is the blood. This is the blood-brain barrier. This is the cerebral spinal fluid, and this is your brain. So when we do dialysis, the first thing that happens, which unfortunately the animation's not working, so basically what happens is you get water and urea leaving the system. Urea slowly goes out of the blood-brain barrier, slower than the water. And you get an effective increase in osmolarity in the CSF and particularly in the brain. So at the end of dialysis, this becomes exaggerated. So you get quite a substantial increase in the osmolarity of the neurons compared to what is going on in the outside of the brain. And ultimately that, at the end of dialysis, causes substantial brain swelling. And imagine the impact it has on patients' fatigue to be undergoing that. Plus you have the effect of removing fluid at such a high rate on these individuals. In one session, we can remove up to 3 liters to 3.5 liters in 4 hours. Is that optimal? No. Is that facilitating involvement in one's environment and physical activity? No. You can see here that there is a linear association of fluid removal. This is ultrafiltration rate in ml per hour per kilogram of body weight, and cardiovascular mortality. So you have at above 10 ml per hour per kilogram of body weight, you have a substantial increase in cardiovascular mortality and a substantial increase in all-cause mortality, which is important to keep in mind. So it's potentially harmful. And in those individuals who have reduced cardiac function, it's even more harmful because they cannot build the cardiovascular compensatory response in this situation. So just these last two